From ARUP Laboratories on the campus of the University of Utah, welcome to the Labmind podcast. I'm your host, Dr. Brian Jackson.
Today is Monday, the 4th of March, 2024, and today we are recording the annual Lab Week episode of Labmind. This year's Lab Week theme is The Lab is Everything, and I'm very excited to have as our guest for this episode, Dr. Eddie Stenehjem from the University of Colorado. Dr. Stenehjem is Executive Vice Chair of the Department of Medicine, Division Head for the Division of Infectious Diseases, and a Professor of Medicine at the University of Colorado Anschutz Medical Campus. Prior to joining the University of Colorado, he spent 11 years in Utah at Intermountain Healthcare, where he was Senior Medical Director of Medical Specialties, where, of interest to us, he also chaired Intermountain's Laboratory Stewardship Committee. Dr. Stenehjem received his medical degree at St. Louis University, followed by medicine residency at University of Colorado, then infectious disease fellowship at Emory, where he also received a master's degree in clinical research. Eddie Stenehjem, welcome to Labmind.
Brian, thanks so much for having me.
So in keeping with the Lab Week theme, let me start off by asking, in your clinical practice, as you're taking care of patients, and I'm assuming most of these patients have some sort of complicated infections, how important is the clinical laboratory to your work as a doctor?
As an infectious disease physician, we get consulted on the patients with the most severe, most complicated infections. We'd love to get consulted on the easier ones because that would make our day easier, but that's not why we're here. So having this partnership with the laboratory, specifically with the microbiology lab, the molecular lab, it's a must-have for patient care. We are working together so collaboratively to try to identify the infections that these patients are infected with and how best to treat them, that we have to have an incredible partnership in order to provide the best care possible. So whether it be accuracy of the test, timeliness of the test, helping determine the most appropriate test, all those things are done in partnership with the lab, and it's just absolutely critical.
Any recent examples come to mind where maybe you were headed down toward one diagnostic pathway and then some sort of insight from the lab led you in another direction, or anything like that sort of come to mind?
Yeah, in my current role at the University of Colorado, I do a lot of transplant infectious disease. And the challenge there's lots of them, but one of them is diagnostics in terms of fungal pathogens in the lung and elsewhere. And one case, I was considering doing a blood test to try to identify what could potentially be causing this gentleman's infection. And when talking to the laboratory, they said, hey, we've got extra sample left over from a bronchoscopy that was done 3-4 days before. Have you considered doing genome sequencing from the bronchoscopy samples? And I hadn't realized that, one, we had sample left over, and two, that was something they were willing to send out. And so it's just an example of how having this connection with your microbiology lab or molecular lab allows you to identify the right test for the right patient and ultimately get to the right diagnosis.
So as an infectious disease doctor, you have had more direct on-site laboratory experience right during your training than a lot of doctors. And so when I think of infectious disease doctors, I think of people with really deep expertise in microbiology and all aspects of testing. Given that you've got a higher level of lab knowledge than the average doc, do you still find yourself contacting the lab with questions, looking for advice, insights, new information?
I would say absolutely, I do. And I would say actually probably we do it more often than others because we know of what those lab professionals know and how they can help. We know that they have this incredible expertise that we need to tap into because quite frankly, they know much more about microbiology than I do. And so I think the benefit of us in infectious disease training is that most fellowships spend at least a month in the microbiology lab, working with our microbiology professionals, learning from them, learning from the different pathways and algorithms that they take through sample preparation and testing. That allows us to have the insight of knowing when to call and also who to call, whether it be somebody who is reading plates or somebody who's setting up molecular tests or somebody working on the urine bench. It allows us to have those connections and develop those relationships. So when they know that Eddie from infectious disease is calling, they know that they're talking to somebody who has the utmost respect for the microbiology lab and what they do. And so I think ID docs really understand the lab intimately and also really understand how much our lab professionals know and utilize them to improve care.
I wonder if this is one of those examples where the more you know, the more you also know what you don't know. And so the more you know what questions to ask.
Absolutely, 100%. We would do antibiotic stewardship rounds where we'd go and we'd review a team's patients to see where they're utilizing antibiotics correctly and where they could improve. And we'd have so many times where we'd review cases and we'd say like, hey, why don't we just call the micro lab and get an answer on that right now? Or, hey, let's call the micro lab and see if they can do a MALDI on that isolate. And it was clear that those learners, those residents, the students, and even the attendants didn't know that that was an option, didn't know that, oh, we can do that, because they just didn't know the questions to ask because they didn't have the knowledge of the workflow of the laboratory. And in many instances, we were able to get diagnoses quicker, get patients out of the hospital, get them on more appropriate therapy quicker. So yeah, the more you know, the more you can utilize the laboratory.
This also speaks to the collegial relationship that you've got between you and the laboratory. Back when we were in medical school, it was pretty normal to walk down to radiology and chat about a case and pull up the films. And clearly infectious disease, you did the same kind of thing with plate rounds. Is it harder in the modern world to have those collegial relationships with specialties like pathology, lab medicine, or radiology for that matter?
I would say it's harder, but it's still critical to have those relationships. Radiology rounds was such a common theme in both my residency and fellowship and early in my career, Intermountain, where complex cases, particularly infections involving the brain and spinal cord, we'd bring the whole team down to the radiology room and we'd pull up all their films and look at progression. And is there progression? Is there not? Do they need surgery? And it was a really high yield conversation with the radiologist because you could glean so much more from talking to them than you could just from their written report. And now that part's gotten harder, like you said. Many radiologists are now off-site. They've centralized it. They may be at their home. Can you get in touch with them? Yes, but it definitely has more steps involved in calling the radiology operator, getting connected to the right person, waiting for that person, as opposed to walking down to the radiology suite and knocking on a couple doors. Microbiology is in some ways headed in that direction with centralized microbiology labs. I've been really fortunate to have worked at two main hospitals that those labs are there on site. And so I could take my team, give them a tour of the microbiology lab, molecular lab, show them the life cycle of a blood culture, for example, to get them to understand kind of what are the different steps and how you can get more information at what step. And at that time, we can also engage with the microbiologists and the techs in the lab and develop that relationship. And so when those tough cases come up and we need to have that conversation with lab, they know who we are. They know that we've been there before. But as microbiology labs are getting off site, it's really hard to do that. We don't have that face-to-face contact. We lose some of that personal relationship and developing those relationships when they're off site. I remember many cases that'll say something about few colonies of X, Y, and Z on a plate, and you'd go down and you ask them to pull the plate, and there's one colony of coag negative staph. And you're like, you know what? That's not real. I mean, it's real, but it's not causing an infection and facilitates better care.
It seems like in the current world of medicine we live in, that the clinical communication all gets mediated by what's in the electronic health record. And that example you just pointed out is one where meaning can get lost when it gets filtered through that electronic interface.
I completely agree. And we've been talking a lot about CMV viral load at our institution right now in the transplant service. And what does it mean to have a low positive CMV? What does it mean to have a CMV of 0 versus 14 versus 88? Are those different? Or is that just in a range of variability in our CMV test? Because, if we report a number, many people say, like, oh, that's what it is. It's got to be that. And, in reality, it's all the same. It's all within the variation of the test.
Yeah, this is something that's always interested me. In life sciences, if you're reading a journal article that has anything quantitative in it, there are always error bars. And in laboratory reports, historically, we haven't presented things graphically. I guess the excuse is that the HL7 interface, and these were developed back in the early 90s, if not earlier, doesn't have a slot for the standard deviation. And not that standard deviation is always technically the right way to present it, but lab results, they don't get presented graphically.
Right. And I can tell you, clinicians see a number and say, that's the number. That's exactly what they have. Their creatinine is 3.6. And yesterday it was 3.4. And so it's going up and their acute kidney injury is getting worse. We hold on to these numbers like that's what it is. And in reality, that's not the case. And, it's interesting. Over the course of the years, we've tried to change the way some lab results are reported and the limitations that we have in that interface, it's incredible. We wanted to be able to put on a Staph aureus, bacteremia, blood culture, a comment to say, hey, this is really bad, high mortality rate. But in reality, we could only use 50 characters because of those interfaces. And I think we could do more in terms of having that communication. But I think, like you said, Brian, it starts with what is the infrastructure, like HL7, like you mentioned, to be able to put in those important comments for your lab results, to be able to get that across to the clinician.
We often in the lab hear a lot of frustration with flagging of results because, again, the system doesn't allow that much nuance. You can label something critical, but there's a difference between life-threatening this hour or this minute critical versus it's critical that someone deals with this within the next few days versus just don't miss a cancer diagnosis. They're all critical in a way, but it's hard.
Yeah, you're absolutely right. But it also enters into the noise of the electronic health record. So the more and more things get marked critical, the less important they become in the eyes of the clinician because so many things are marked critical. So many things are in a red box versus a black box. And having the ability to flag things is like, hey, you need to address this now versus like, hey, this is important. It's super challenging given the amount of information that is coming at our clinicians that are taking care of patients.
So it's becoming more and more common for patients to review their own lab results, increasingly online. Sometimes they get printouts. Does that create new levels of challenge? And not only do you have to interpret the lab results, but you also have to manage sort of the patient's understanding and their anxieties.
Yeah, absolutely. I mean, it goes well beyond lab results. They're also getting radiology reports and pathology reports and your clinical notes. The minute that they are hitting the EHR, the minute you sign your note, they can review them. They get an email saying, hey, something's updated. And so it's not uncommon for me to walk into a patient's room in the morning on my morning rounds in the hospital and them to say like, hey, I saw my chloride was a little high today. What do you think about it? And so they're actively reviewing their laboratories and their notes, and they're saying, hey, Dr. Eddy, I saw this is what you wrote in your note yesterday. I don't remember us talking about that. And so it is definitely ushering in a new era of transparency with patients. And I think that's good. That is their medical record. Those are their lab tests. They have every right to be able to have insight and visibility on those. What I think is hard is when a new diagnosis comes, a radiology report shows a new lung lesion, a pathology report says recurrent breast cancer. When they're getting that information first, without a clinician explaining to them, taking the time to sit with them, saying, this is what this means, oh, that's really hard as a patient to be able to sit with that unknown until they can speak to their clinician. And many times it could be days. Those are things that I think we have to struggle and wrestle with as a medical community about how best to communicate that to our patients because they are seeing it and they're seeing it alone and they're getting scared and they're not having that person walk them through that diagnosis. I think we're moving in the right direction, but we have a ways to go on it.
So one thing you're pointing out in all of these different examples is the importance of communication, that effective communication between the lab and clinicians, between clinicians and each other, clinician to patient. There's just so many different aspects here. In your years of both training and medical practice, as you've worked with different laboratories, can you think of any examples of laboratories that have been particularly good with communication? Or can you think of maybe some aspects of the ways that some laboratories communicate that are maybe noteworthy?
Absolutely. And I was just so fortunate to work with an Intermountain laboratory that was just so collaborative and collegial. And Bert LaPansery was our medical director of microbiology. And he was just such an incredible clinician, but also a laboratory professional. And some of the things that I kind of learned through my years there and through leadership is a couple of things. One is nobody reads emails. And so if you think that your form of communicating a lab update to the medical staff is going to be an email, and then that's going to be effective, the first to tell you that's not going to be that effective. And so I think the most effective strategy that we've seen over the years is having the medical director or somebody equivalent go to those service lines or clinical programs, however you name them, that is going to be using that test most frequently and give them an update. You know, we all have standing, typically monthly faculty meetings, whether it be in the emergency department or infectious disease or cardiology we all have monthly standing faculty meetings. And your idea is like, hey, I'm going to change the respiratory pathogen panel for the emergency department. And an email to the emergency department, it's not going to do the trick. They're on shift schedules. Many of them are not super attuned to their emails, but going to their faculty meeting and saying, hey, I've got 5 minutes. I want to give you the update. This is why we're changing it. And this is what you're going to see. And here are important aspects of the test. That gets included in the minutes. That gets sent out. That's going to be much more effectively communicated than an email that could be potentially an entire page that doesn't get read. So I think you need to have multiple forms of communication, but really important changes in the laboratory, whether it be in chemistry or micro or molecular, really needs to have some face-to-face communication with the leaders that it's going to impact the most, whether it be hospital medicine, critical care, emergency department, infectious disease, cardiology. But taking that time and making sure organizations see that and value that time, because that's work. And so those medical directors, those leaders need to have the time built into their contracts and their days to be able to go to those meetings and have those conversations and let clinicians ask questions about the test. And so I think it's multifaceted forms of communications, but some of it has to be face-to-face or virtual where clinicians have the ability to ask questions. And yes, the standing email is likely not going to be really engaged with, or an alert in the electronic health record. I've seen that too, where you log on, you get an alert, oh, something changed. And the clinician, what you're trying to do is you're trying to get to your patient as fast as you can. And many times those alerts go unacknowledged.
I would think that this sort of thing would also just help with relationship building, having some face time and being seen.
Absolutely. Maybe, when I think about Bert Lepansery's, relationship with all the different groups in Intermountain, he'd be the first to tell you that, oh, yes, it helps with the relationship building because now he's getting called by all these people because they know who the point person is for microbiology or molecular. But you're absolutely right. It leads to better relationships. And we see that, not just in laboratory stewardship. We see that in my example is, tele-infectious disease. Being able to get on a call as you're taking care of patients in different cities and talk to the clinicians, like that's really important. Shows that you're there for them. They trust you. They put a face to the name. You're not just some anonymous note that pops up in the chart. But yeah, I completely agree.
Maybe this is a new quality metric for laboratories to count how many phone calls you get. And if it's too low, there's something wrong. You're not available enough. Seriously, I think a lot of labs don't get any phone calls. And I think that's a red flag. Either people don't know how to call or they don't know whom to call. It's too hard to find the number, or maybe they get put on hold too long. There could be a lot of reasons.
And I think one of the reasons that I would call the lab all the time, maybe too much, is that I knew the direct line to where I was calling, right? The direct line to micro, the direct line to molecular. And then I knew once micro picked up and I had a urine culture, I'd immediately say like, hey, Betsy, can you send me to the urine bench? Sure thing, Eddie. And off they went.
Let me change directions a little bit. This is sort of a curiosity question. I've often thought about the role of speed in lab testing. On one hand, all laboratories measure turnaround times, but I sometimes wonder if they get measured from an internal perspective, just making sure that turnaround times are consistent. But when you think about how long it takes to get a lab result back, what's sort of your mental model?
Yeah, it's all about what lab are we talking about and, what's the current technology that we have. I think COVID is a great example. So we have now moved from when we first encountered with COVID, we'd get a sample, send it to the CDC. CDC would do the processing, and you'd get a result back 10 days later, maybe 2 weeks later. And by the time you got the result, the patient was either critically ill on event or home doing absolutely fine. So, at that time, the lab's value was epidemiologic purposes only, right? It was tracking to see where is the virus, who's getting it. But when you're getting a lab back 10 days to 14 days later, it's not impacting the care that you're delivering. Now move up in time and those lab tests are now coming back in 24, 48 hours. During drive-through testing, you could get a result on your phone in 24 hours, 48 hours. And that had impact, right? That impact on the patient in terms of, am I going to isolate? Can I go to that party? It had really significant impact. And then moving it farther up, we had essentially rapid diagnostics in terms of somebody comes into the urgent care, swab, put in the Cepheid machine, an hour later, got your answer. And then that's really where we could say, okay, now we've got a test within an hour. Patient symptoms started a day ago. I'm going to give them an antiviral because I know that they're going to have an impact, right? So I think it's all about the test and the accuracy of that test. Then you move into rapid antigen test. You have it immediately or in 8 minutes, but the accuracy isn't great. How do you use that? How do you interpret those results, and how do you back those up? I think then in direct contrast, do a blood culture. When I started training at Emory University and the blood culture, you'd get a positive, microscan alert. You'd get a gram stain, and then you'd set it up on the microscan and you'd wait another 24 hours. And you might be getting an ID and susceptibility 48 to 72 hours. That's all went well. Now we're getting tests directly from a positive blood cultures. We're getting things directly from blood. And so as we're getting those results faster, making sure those results are coupled with the clinical teams so they know how to interpret it, has become more and more critical. And so as I think about turnaround time in the microbiology sphere, it's all dependent on the test and what new technologies can the lab get in, not for the sake of getting new technology in, but for the sake of speeding care along, right? So we are now knowing that, this is MSSA, bloodstream infection, not MRSA. I'm going to get them on an antistaphylococcal penicillin and not wait the 48 hours to switch their Vanco. I now know this gram-negative bacteremia because we moldied it is Klebsiella. And now I'm going to put that on some kind of molecular panel to know if it has an ESBL genetic determinant or a KPC. And if it does, now I'm going to change it to meropenem from ceftriaxone to make sure that they're on the appropriate therapy. So turnaround time for me is all dependent on the technology and what technology the lab has that we know that will improve care, and how is that communicated to the frontline teams in the clinic. It's gotten really complicated when we talk about molecular diagnostics.
And so another factor that adds into that is location. You mentioned earlier centralizing laboratories, which can be a lot less expensive, but it adds in transportation time. There's another example of a health system I'm somewhat familiar with in the Northern Midwest that very explicitly decentralized a lot of chemistry testing for the outpatient setting so that patients could get their test results on the same day of their clinic visit rather than getting them the next day. So a lot of really complicated cost-related decisions that touch both technology and location. I would hope that laboratories are having deep conversations with medical staffs as they make those decisions.
And you're absolutely right. I mean, if you look at where healthcare is going, it's formations of healthcare networks, healthcare systems. There's mergers and acquisitions, albeit slowing down now, but the vast majority of hospitals are part of healthcare networks. And as you join healthcare networks, you lead to centralizations of some key functions from a cost saving standpoint, which is absolutely correct thing to do. But determining what stays local and what goes centrally is challenging. And, we've seen variability in that, in the fact that we had some hospitals that were relatively rural bring on molecular panels for blood cultures because they would send them to a central lab to get worked up. But before they did that, they could run the molecular panel to say, hey, at least we got a prelim ID and I have to wait. And so I think you're right. What's the cost-benefit analysis of decentralizing some of these critically important tests, and how does that impact the care received in these communities? Do they get better care, more timely care? Can they stay in their communities and not have to be transferred? Those are all critical questions.
It seems to me that with serious infections, the time factor is often more critical than just about any other medical specialty.
Yeah, we know that time to appropriate antibiotic is a critical quality measure, right? And if the longer you go, the worse outcomes you have. And what ends up happening, and my experience in these smaller communities that don't have access to rapid, whether it be molecular diagnostics or even just routine microbiology, is that they stay on broad spectrum therapy longer, broad spectrum antibiotic therapy longer. And so patients now are on vancomycin and meropenem as they're waiting for an ID and susceptibility, and that leads to downstream consequences, right? And harm to the patient, development of drug resistance, longer hospital stays. It's critical in our field.
I'm very interested in your experience on both the Intermountain Lab Stewardship Committee, but also your long experience, and I know this is your area of academic specialty as well, with antibiotic stewardship. So could you give a little bit of background for how the Lab Stewardship Committee at Intermountain Healthcare works?
Yeah, sure. I had the good fortune of taking over the lab stewardship committee kind of mid-pandemic. And this committee had been set up prior to the pandemic. It's been in existence for a few years. And it was co-led by the leader of our pathology group, which also had lab underneath them, and the senior medical director of medical specialties, a clinician. So it was led by a lab leader and also by a clinician leader. And we thought it was important to make sure that those two people were merged together. So you had somebody who's really focused on the laboratory and then somebody who's really focused on clinical care leading the group. And then in amongst the group, the committee was made up of quite a few people. We had some people from the lab. Micro medical director was part of the committee. I was part of the committee as an antibiotic stewardship leader because it has a lot of overlap with laboratory stewardship and how we do different interventions and how we implement. We had leaders from critical care, from hospital medicine, because they take care of so many patients of ours that they were critical to have on the team. We had somebody from Select Health, our insurance arm, being part of the group as well to make sure that we were up to speed on some of the payer regulations and laboratory testing. We had a pharmacist on the team that was actually our infectious disease pharmacist, given her experience in stewardship. We had people from surgery because they obviously take care of a lot of people as well. And then we actually had representatives from ARUP on the committee as well, because that was our send-out laboratory. So it was really a multidisciplinary team that was co-led by a laboratorian and a clinician that was really tasked with a system-wide approach to laboratory stewardship. It wasn't one hospital, it wasn't one clinic, it was Intermountain Health. And at that time, that was 23 hospitals, 180 plus clinics. And so we really had a system-based approach to how we set things up.
How would you describe the mandate of the committee? Was it all about cost savings, for example?
So we had a mission vision statement, and I like to say I could remember it off the top of my head. I can't. But it really was identifying the right lab for the right patient at the right time. So this wasn't a cost-saving initiative, albeit we did have cost savings. I mean, that's definitely was a result of some of the work we did, but making sure that we added value to the patient. And sometimes that was not doing a test, but other times that was adding a test that they needed. So we wanted to make sure that the right test was getting done in the right patient at the right time that would add value to their care. And that's kind of how we approached. And we were able to go through our laboratory catalog, looking at most commonly used tests that were very expensive, that needed to have some oversight, tests that we knew didn't add much value just based on the literature, and looking at numbers and distribution of that test. Think of like ammonia levels, not very useful. And so how do we minimize those? And then being able to create a visualization to be able to show the impact our committee had and have pretty granular data down to the physician, clinician level to be able to show who was ordering these tests and where. So that was kind of our mandate. And then it was up to us to determine which tests do we tackle.
So just off the top of your head, if I say overused test and underused test, any examples come to mind?
Yeah, overused tests are some vitamin D tests that don't have any clinical relevance. Ammonia, most times, doesn't have any clinical relevance. A number of endocrine tests, in addition to the ones that I've mentioned, don't have much clinical relevance that are often done. And then other overused tests are the big respiratory and GI pathogen panels, the big multiplex panels that in many cases in immunocompetent people don't give you much actionable information aside from influenza, RSV, and COVID, but yet come with a lot of other targets on it. Same thing with the GI film array. Great test in the right patient, but many times overused and incredibly costly. So those are some of the things that we think about, kind of overused tests. Underused tests, HIV, for example. We know that we are not screening people for HIV appropriately.
How do you know that? What kind of numbers do you look at for that?
So it's hard to get good solid numbers on that, but we know there's CDC recommendations for HIV testing once in your life if you're low risk and between a certain age group. And so we're able to look at primary care panels and say, okay, of these people, have you ever had an HIV test? The majority are no. For people that are coming into the emergency room or urgent care and coming in because they're symptomatic for gonorrhea and chlamydia, they may have vaginal discharge, they may have burning on urination. They're high risk in terms of sexual partners. They're coming in because they're concerned about a sexually transmitted infection. And we look at, of those patients that are tested for gonorrhea and chlamydia, how many of them are also tested for HIV, syphilis, hepatitis? The answer to that is incredibly low. And those are people that absolutely should be tested.
Yeah, you hear about syphilis being a huge problem right now.
Yeah, syphilis is on the rise. Congenital syphilis is on the rise. We have a poor ability to get penicillin, the drug we treat syphilis with. So it's a real challenge, and we got to know the diagnosis. And so making sure that these tests are done and done appropriately in the right clinical situation, really important. So there's definitely tests that we need to be using more of, that we have to figure out how do we change our EHR to maybe escalate an alert to say like, hey, I saw you ordered these 2 tests in this patient. They haven't had an HIV test in the past 2 weeks. Do you want to order one? And how do we make sure that we're not missing barriers to getting that test done? You know, the example I talked about, HIV and people that are coming in with sexually transmitted infections, a big barrier is cost. So they're coming in, HIV is an additional cost to them. They're worried that if they're a young person still on their parents' insurance, that test is going to show up on the insurance bill, right next to gonorrhea and syphilis. And so now that's going to their parents, right? That's a challenge as well. The clinicians may be worried, like, I'm not sure what to do when I get a positive result. And so Intermountain has created these wraparound services where if you get a positive HIV test, infectious disease will be involved in the next 24 hours. We're going to do a tele-visit with that patient, regardless of where they are, to make sure that they feel like, hey, I got you. You're safe. Let me tell you the next steps. Let's get you in the clinic tomorrow. Get you started on antiretrovirals. It's not just, oh, you should do more of that test. What are the other barriers to getting that test done more appropriately? It's a lot more than just a knowledge issue for the clinician.
So over the years that you are involved with the lab stewardship at Intermountain, what would come to mind as sort of the biggest successes? Or what kinds of things was the committee most proud of having accomplished?
Yeah, so Bert Lepansery led this work on really making sure that the right people were getting the respiratory pathogen panel test at the right time. And so making sure that the patients that needed it the most, those that are transplant patients, those that are immunocompromised, those that are receiving chemotherapy or high-dose steroids, those are the people we need to make sure that we're using that test on. But the person that comes in who's immunocompetent, that those tests aren't going to have a big impact, those aren't going to be getting that. And so before COVID, we led this really great work, and we used EHR tools to risk stratify people to ensure that the people that needed the test the most got it, and those that didn't got alternative tests. Not no tests, but alternative tests. Let's make sure they get an influenza test, for example, because that has implications of whether you start Tamiflu. So that was a really big, important aspect of the work we did, because it made sure people that needed the test got it, and those that didn't get it. And then, you know, some of the other work that we did was really trying to get rid of low-value tests. And so we were able to track low-value tests. We've named a couple of them. Ammonia is one that just is easy to come to mind. And we were able to track it. And we were able to show that with our interventions that were often EHR, electronic health record based, plus education, plus transparent data, that we had really big impacts on laboratory volume. So not only did it save the patients money, but it also decreased time and effort on the lab. And so they could be using their time more effectively. And so we were excited about kind of the work that we had done. We had doubled the amount of HIV testing that we did in symptomatic patients in the urgent care and emergency departments. And that led to new diagnoses of HIV. That led to people getting on care. That led to people not transmitting HIV to their partners. And so there were really kind of tangible benefits to the work we did, not just from a healthcare economic standpoint, which there were some, but also from ensuring patients got the best care possible.
So I'm thinking about this in terms of some of the lessons that laboratorians can pick out of the things that you've said. You talked a lot about the importance of the multidisciplinary nature, that you had people coming from lots of different clinical areas in addition to the lab. And the example you just gave about respiratory panels, I thought was interesting, because it's not saying that these broad panels are a bad test per se, but that you need to know the clinical context to know whether it's the right test or not, which is very different from just saying tests are either good or bad.
Totally. Tests are great in the right patients, right? Most tests have a dedicated patient population, and it's ensuring that those tests are utilized in those patients appropriately.
So this brings up a philosophical question. that would relate to any kind of a clinical oversight function. How do you respect physician autonomy and physician expertise when you're doing something like a stewardship committee? How much deference do you show? When do you need to worry about being heavy-handed? But at the same time, you want to be effective. You don't want to just give soft advice out. So how do you think about the autonomy issue in medical practice?
I think about that a lot, right? One, because I'm an active clinician. And two, is that, over my years, I've kind of oversaw antibiotic stewardship and laboratory stewardship. So I couldn't just let clinicians say, oh, let me have my autonomy and my meropenem at the same time. That wasn't part of my job. So some of the tactics that I think about is, what is that shared baseline that clinicians can agree upon that would apply to 80 to 90% of patients? What does that clinical guideline look like for the treatment of sinusitis? And we all agree upon that the majority of patients that meet these clinical criteria should get amoxicillin for sinusitis as opposed to Labmind. We can all agree upon that. That's where we start. And so we come to this developing a shared baseline of how to manage a certain disease state, whether it be sinusitis or diabetes or heart failure. And then it's the clinician's job. We demand it out of the clinicians to identify the people that fall out of that 80 to 90% of people that algorithm, protocol, whatever you want to call it, applies to. The job of the clinician, the astute clinician, is to recognize when you have to deviate for a particular reason. Right? And there are lots of reasons that you would need to deviate from a protocol. And it's really up to that clinician to be able to determine who are those people. Who are the people that this doesn't fit? Maybe this patient got treated with amoxicillin 10 days prior and it's failed. And now you need to expand therapy. Maybe this person has a severe drug reaction to a particular medication, has to use something else. Whatever it might be, it's that clinician's job, it's their duty to be able to identify those patients that don't meet those requirements. And that's where the autonomy piece comes in.
So in practice, how do you manage that? By way of illustration, one way of quote unquote implementing a guideline is to make the clinicians jump through some time-consuming hoops in order to deviate from the guideline. But that's just throwing up barriers. But that happens in some settings.
Oh, yeah.
Are there other mechanisms that can allow them to deviate, but without completely neutralizing the effect of the governance?
Yeah, I prefer, if you can, you do this with data as opposed to annoying hoops you have to jump through in an EHR. Click, 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 click. Yeah, it's fine. But my preference is that somehow you're able to extract data from the EHR that allows you to determine whether or not clinicians are treating a particular condition appropriately. And so much easier said than done, but with some intentional focus on it, you can create algorithms that have decision tree points that you're able to extract from the EHR. So whether it be antibiotic prescribing in respiratory encounters, whether it be first-line therapy in urinary tract infections. There are tools you can create in the EHR that pulls data at the clinician level that looks at ICD-10 diagnosis and looks at antibiotic prescribing. And that's up to us to look at that on a particular interval, typically quarterly or depending on how many times these cases come up, and say, who's falling outside the normal bounds of appropriateness? And so then we can say, like, hey, in this 3-month period, we saw that Dr. Jones prescribed fluoroquinolones for UTIs 50% of the time. That's too much. Let's go have a conversation with Dr. Jones. And so if you can use data to drive change and not necessarily put up more barriers, that was the ideal situation. We did that in the lab stewardship kind of group as well. And we said, we're the top 10 orderers of ammonia. And it turns out those 10 individuals accounted for about 40% of our ordering practices of ammonia.
Interesting.
So you know what we did? Let's go talk to those 10 as opposed to talk to the hundreds and thousands of clinicians, which have been a lot more laborious and time-consuming. So using data to identify the outliers, identifying the people that aren't following appropriateness or guidelines or protocols, whatever you want to call it, and then circling back with that, we call that prospective audit and feedback, is really an approach that you can use to minimize a lot of the clickety thing. Now, I would say we did implement a hoop at Intermountain, and that was because we weren't having a whole lot of traction and we needed to change practice. And so we know that macrolides, azithromycin, shouldn't be used in respiratory infections. The pretty much only used in pediatric patients with group A strep that are allergic to penicillin. But when you look at respiratory prescribing as a whole, they're used a lot more often. And so we needed to minimize that use. And the way we did it was exactly what you're talking about. We created a pretty obnoxious alert that they had to go in and click why they were doing it. And if they didn't meet one of those criteria, they had to click a different box and tell us why. And then that would go into the EHR. And that was intentional. That was intentional for us to say, like, we're going to make this hard for you to order this drug. But that was an intentional play. It worked great. Worked really, really well. It drove azithromycin from 8% amongst respiratory encounters to 2%.
It's a big change. So it's good to have a range of tools, it sounds like, in these settings.
Absolutely.
Okay, so final question. We have a lot of laboratory professionals who listen to this podcast. So again, in honor of 2024 Lab Week, any final message that you'd like to share with the laboratory community listening to this episode?
Thank you for being part of the team. It takes a team of people to care for patients, whether that be inpatients that are in the ICU or outpatients in the clinic. I think the physicians, the APPs, we get the attention, right? We're the ones that are face-to-face with the patient, but it's much more than just us that are taking care of the patients. And the laboratory has a critical role in caring for patients. They may only see their specimen and the results of that, but that is part of this large team that's caring for patients. And I just want them to know that they're as part of the team as anybody else is, whether they're seeing the patient across the exam table or at the bench. Thank you for being part of that team. Thanks for allowing us to be able to care for our patients the way we do. And we're so grateful.
Dr. Eddie Stenehjem, thank you so much for being on Labmind today.
Hey, thanks so much for having me.
Labmind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta-Alvarez. You can also find other Labmind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to Labmind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.